Welcome to our video accompanying the article in Gastrointestinal Endoscopy entitled A Standardized Imaging Protocol for the Endoscopic Detection of Dysplasia within Sessile serrated polyps. Sessile serrated polyps account for approximately 8% of colorectal polyps in screening populations. Sessile serrated polyps with dysplasia are significantly less common, however. SSP with dysplasia may be mistaken for adenomas and incomplete resected, potentially explaining some of the rate of interval cancer after colonoscopy. Therefore, it is critical to be able to completely define these lesions, appreciate areas of dysplasia, and therefore resect them completely. In this study, we aimed to describe the accuracy of a standardized endoscopic imaging protocol for dysplasia within sessile serrated polyps. We recruited 141 consecutively detected sessile serrated polyps larger than 8 mm into this study in 83 patients. These lesions were completely imaged with high-definition white light and narrowband imaging, and a structured datasheet completed with the study coordinator describing aspects of the lesion and aspects of the endoscopic features of dysplasia. Mainly, a demarcated area was sought within the serrated tissue containing either NICE type 2 or Kudo type 3 or 4 pit pattern. If this area was detected, the lesion was labeled sessile serrated polyp with dysplasia. If it was not detected, the lesion was designated sessile serrated polyp without dysplasia. After completion of the datasheet, the lesions were completely resected using either endoscopic mucosal resection or cold snare polypectomy, and the specimens submitted for histopathological analysis. The analysis of histopathology was by blinded specialist gastrointestinal pathologists. We found in the 141 consecutively resected SSP that 36 contained endoscopic evidence of dysplasia. At histopathological analysis, the blinded gastrointestinal pathologists did not detect dysplasia in 10 out of these 36 cases, leading to an accuracy of 91.4%. At this point, we undertook a structured discussion with the specialist gastrointestinal pathologists and the endoscopists. During this discussion, 5 of the lesions previously designated non-dysplastic by the histopathologists were revised, and therefore 5 out of the 36 at the end of the structured discussion did not have histopathological analysis containing dysplasia. Therefore, the overall accuracy of the standardized imaging protocol after structured discussion was 95%. In the manuscript, we have included multiple images of sessile serrated polyps with dysplasia, and we have included all of the examples where endoscopic imaging and histopathology disagreed. We would encourage you to review these images because we think almost certainly that they will be of great use in your day-to-day practice. In conclusion, endoscopic imaging can reliably determine the presence of dysplasia within sessile serrated polyps. This is a finding of great importance since the underappreciation of dysplasia within sessile serrated polyps may potentially result in their partial resection and the leaving in situ of a high-risk serrated tissue with the potential to rapidly progress to colorectal cancer and potentially interval cancer. In addition, this endoscopic imaging protocol will enable endoscopists to completely appreciate the extent of sessile serrated polyps with dysplasia and plan their complete resection, thereby improving outcomes for all our patients. We recognize that this study was conducted in a single center, and while there were multiple endoscopists in the study, these findings require independent validation. However, if independently validated, these findings may be significant for the future management of sessile serrated polyps endoscopically. We thank you very much for your attention and hope you enjoy reading the manuscript.